Bismillahirrahmanirrahim. My presentation today, how to protect cancer patients and healthcare workers from COVID-19 era. Introduction, according to recent guidelines from China National Health Commission, pneumonia caused by COVID-19 was included as Group B infectious disease. However, current guidelines suggest ensuring protective measures for all healthcare workers similar to those indicated from Group A infections like cholera and plague. WHO confirmed about 80,000 cases and about 770 patient deaths, about 9.6 during the SARS-1 outbreak in 2002, which healthcare workers accounted for about 1,700, about 21% of cases. What about SARS-2 or COVID-19? It confirmed about 59 million cases and about 1,399,000, about 2.3 deaths from the COVID-19 SARS-2, of which healthcare workers accounted for 7,000, about 0.5% of cases. These are outbreaks, but the mortality percentage is less than the SARS-1. Recent evidence suggests that even someone who is non-symptomatic can spread COVID-19 with a high efficiency, and conventional measures of protection such as face masks provide insufficient protection. A boy aged about 10 years who was infected with COVID-19 had symptoms but had visible changes in lung imaging and blood markers of the disease. Also, another patient undergoing surgery in a hospital in Wuhan infected 14 healthcare workers even before fever onset. Additionally, a medical expert who visited Wuhan to investigate the COVID-19 outbreaks after returning to Beijing initially exhibited conjunctivitis of lower left eyelid before the appearance of catarrhal symptoms and fever. So, the individual tested positive for COVID-19, suggesting estropism to non-respiratory mucosal surface, thus limiting the effectiveness of face masks. The history of coronavirus in Egypt, starting from the February 14, confirms the first case. It is an African first case presented. As you know, it is starting in Wuhan, in China, in December 31. Starting in Africa, Egypt, after about 2.5 months. Now, the number of patients is about patient infected is about 113,000, and the disease is about 6,548 patients. So, how to protect the cancer patients? Hertuka and his colleagues show that published in Annals of Oncology that the cancer patient has a higher incidence to be infected with coronavirus than the normal population, and also the death rate is higher in cancer patients when infected with coronavirus than the normal populations. So, cancer patient demonstrates a markedly increased COVID-19 mortality rate compared to non-cancer, and all New York City COVID-19 patients. Mortality rate in cancer patients with COVID-19 were significantly higher when compared to all New York cases, 25% versus 14%. There were a 55% mortality among lung cancer, 14% among breast cancer, 15% for genitourinary, and 38% for GI cancer patients. This is published this year in the ASCO 2020. The cancer patient demonstrated a markedly increase in a COVID-19 mortality rate compared to non-cancer in patients admitted to ICU. The case fatality rate in cancer patients with COVID-19 was 19% in elderly patients more than 75 years old. The overall mortality rate in cancer patients was 8%. So the conclusions from this data from New York, older age number of comorbidities, acute performance status more than 2, active cancers and chemotherapy alone or in combination increases the risk of mortality in cancer patients with COVID-19. Preparedness and facilities planning not only for treatment of suspected and confirmed cases of an epidemic disease, but also for treatment of cancer. Cancer treatment priorities should balance intervention based on the magnitude of benefit and the clinical setting. I will give you 2 examples for the ESMO priority categories. So, infection prevention and control of COVID-19. Limit human-to-human transmission, reduce secondary infection, prevent transmission through amplification and super spreading events. This can be started with hand wash, avoid contact with sick people, don't touch eyes, nose, or mouth with unwashed hands, don't eat raw foods through thoroughly cooked meat and eggs, avoid contact with animals and animal products. If you are infected, stay at home. Avoid contact with others. Cover your nose and mouth when sneezing. Keep objects and surface clean. Wear a surgical mask. So, what about the patient education? Coronavirus symptoms, diarrhea. The most common symptoms now are shortness of breath, high fever, vomiting, pneumonia, and coughing. The second wave of COVID-19 has GI problems like diarrhea and vomiting more than the first wave. So, practical suggestion on how to implement the cancer care during the COVID-19. This is need a case-by-case evaluation, very anti-infective measures, and how to decrease the number of patients of the outpatient clinic, and also in the inpatient, like in the National Cancer Institute, you should limit the IV treatment as you can and give the oral treatment and decreases the follow-up rate for the patient in the outpatient clinic. In our institute, National Cancer Institute, we stop working for 2 weeks, do sterilization and disinfection to the whole place and medical device. Patient education webinar was done. Oral treatment as tyrosine kinase inhibitors, hormonal therapy, chemotherapy can be received by relatives and given for about 2 to 3 months. Decreasing number of caregivers. Stop follow-up for patients who are currently in a follow-up out of active treatment. Healthcare worker education about how to deal with the patient during COVID-19 era. Every person entered to the outpatient department goes through electronic disinfectant kits, which has no clinical studies about their effectiveness, and some cases say that this is not effective, so others say that it's effective. It is still used even in the second wave. Patient and caregiver should wear masks before entering the OPD. And we go to do a new protocols with chemotherapy were applied for most common patients, especially in a chronic disease, in a hematological chronic disease patient. So, how to protect the healthcare worker from COVID-19? Healthcare worker and the COVID-19, as you see from this is a very large number of the healthcare worker were infected from the patient. So, the standard precaution. A set of practices that are applied to the care of patient regardless of the state of infection, suspicion, or confirmation in any place where health services are provided. A standard precaution hand hygiene, use of personal protective equipment, which is PPE, according to risk, respiratory hygiene or cough equipment, safe injected jam practice, sterilization, disinfection, medical devices, environmental cleaning, contact precaution, droplet precaution, and airborne precaution. A risk evaluation on PPE, type of interaction with the patient, mode of transmission of the disease, amount of body fluid that will be generated. So, gowns. Gowns are used in addition to gloves if there is a risk of fluids or blood from the patient splashing onto the care worker's body. The same gown can be used when providing care to more than one patient, but only those patients in a cohort area, and only if the gown does not have direct contact with the patient. Plastic aprons should be used in addition to gowns if the material of the gown is not fluid repellent, and the task to be performed may result in splashes onto the healthcare worker's body. About the facial mucosa protection, face shield, eye visor, goggles. Mask and eye protection such as goggles are also important pieces of PPE and are used to protect the eyes, nose, or mouth mucosa of the healthcare worker from any risk of contact with the patient's respiratory secretions or splashes of blood, body fluid secretion, or excretion. This is the method how to put a PPE, how to use the gown and the mask face and the gloves, and how the doffing of the PPE. Respirator N95 or a medical mask. There is a lack of research about the use of the N95. Many persons advise, or many physicians advise to use the N95, but as I know, there is no strong data about that it will prevent the infections of COVID or other infections, especially when comparing with other masks. In a SARS care often necessitate aerosol generating procedures such as intubation, which also may have contributing to the prominent nosocomial spread, the factor associated with transmission of the SARS-CoV ranging from self-limiting animal to human transmission to human super spreader even remaining poorly understood. This is the data from all the data from the SARS-1. So, medical mask droplet precautions. Wear a medical mask when within a 1 meter range of the patient. Put the patient in a single room or in a room that contains only other patients with the same diagnosis or similar risk factor, and ensure that every patient is separated by at least 1 meter. Ensure that the transportation of a patient to area outside of the designated room is kept to a minimum. Perform hand hygiene immediately after removing the medical mask. About the respirator N95, use a respirator whenever entire and providing care with the patient isolation facility, ensuring that the seal of the respirator is checked before every use. Perform hand hygiene immediately after removing the respirator. Aerosol generating procedure is very important. What about the blood shortage during the COVID-19? You can make a difference. Follow the RBC's guideline, transfuse 1 unit at a time with an ongoing reassessment. Blood is really needed when the hemoglobin is more than 7 grams per liter. Don't transfuse RBCs for iron deficiency, even if less than 7. Follow platelet guidelines. Prophylactic platelet transfusion is generally not required when platelet more than 10,000. Careful consider of frozen plasma. Fresh frozen plasma does not improve mildly elevated INR. Correction of the mildly elevated INR or PTT before most procedure is not recommended. Non-bleeding patients with cirrhosis or end-stage liver diseases rarely need fresh frozen plasma. Use of BCC for reversal of warfarin only when clinically indicated, like major bleeding. Avoid iatrogenic anemia. Don't perform laboratory blood testing unless clinically indicated. Hemorrhage. For treatment of hemorrhage control, use tranexamic acids early for trauma and orthopedic, spinal, or cardiac surgery. In summary, the use of personal protection equipment by healthcare workers requires an evaluation of the risk related to healthcare-related activities. The following precautions are recommended for the care of patients with suspected or confirmed cases of COVID-19. For any suspected or confirmed case of COVID-19, standard and plus contact plus droplet precaution for any suspected or confirmed cases of COVID-19 patients. Standard contact airport precautions. All healthcare workers at National Cancer Institute Cairo, OPT, should do working 1 week and take 2 weeks off. Go through the electronic disinfectant kit, wear gloves, N95 mask, face shield, and gowns. For patients who are currently in a follow-up out of active treatment, oncologists should consider to avoid disease-free patients coming to the hospital for routine follow-up visits. A phone call, online exchange of clinical documentation can be useful to reassure patients and refrain from consultation at the hospital except for the case of an emergence of new symptoms or new clinical or radiological signs of disease progression. Regarding admission to the hospital, outpatient schedule for treatment should come alone and avoid the assistance by a caregiver except for documented need of continuous assistance. Triage of patients with fever and or respiratory symptoms is essential to prevent exposure to other patients and healthcare providers. Our young oncologist perspectives on protection against COVID-19 can be summarized by making the same acronyms YOP protect yourself and your family, oncological care, and patients care. This is the YOP of our young oncologist perspective for being prevention of the infection. And now I go to for the how to care about the hematological malignancies. I will give two examples of this. The ESMO guidelines how to manage multiple myeloma patients. This is the entire approaches for ESMO in delivering a guidelines for cancer patients. This gives us three priority. A high priority, this is one. Second one is the medium priority. Third one is a low priority. Defined according to certain of cancer care of Ontario, Cancer Institute, and the others field. The higher priority patient condition is immediately life-threatening, clinically unstable, and or the magnitude of benefits qualifies the intervention as a high priority, like significant overall survival gain and or substantial improvement of quality of life. Medium priority, patient situation is non-critical, but delay beyond 6 weeks could potentially impact overall outcome and or the magnitude of benefits qualifies for intermediate priority. Low priority, patient condition is stable enough that the service can be delayed for the duration of the COVID-19 pandemic, and or the intervention is non-priority based on the magnitude of benefit. No survival again with no change or no reduced quality of life. In a multiple myeloma, young transplant eligible patient, high priority patient, this treatment should not be postponed. Therapeutic decision should be made as a case-by-case basis, considering disease stage, risk, age, cytogenetic comorbidities. Consider GCSF support to minimize risk of neutropenia. About the medium priority, consider delaying autologous stem cell transplant and prolonged induction regimen for up to 6 to 8 cycles. Patients scheduled to undergo autologous stem cell transplant should be tested for COVID-19 before stem cell transplant. For standard risk patient, consider delaying stem cell transplant by additional induction cycle and or lenalidomide maintenance. This is not proven overall survival benefit for early treatment in this setting compared with modern drug induction followed by lenalidomide maintenance therapy without stem cell transplant consolidation. Use interval phone and or virtual visits whenever possible to monitor tolerability of treatment to decrease clinical visits. Consider extending access to lenalidomide for up to 2 months for patients receiving maintenance therapy with telemedicine, remote lab tests in between. In a patient in need for IVIG replacement, consider administration at reduced frequency, and you can use the subcutaneous form. Consider GCSF support to minimize neutropenia. It's a low priority patient. Delay for up visits and or performed by telemedicine if possible. Delay anti-resorption therapy, zolidronic acid, denosumab, and or reduce the frequency like every 3 months. What about elderly transplant in an eligible patient with newly diagnosed myeloma? The high priority treatment should not be postponed. Therapeutic decision should be made on case-by-case basis, considering disease stage, risk, age, cytogenetic, and comorbidities. Consider G-CSF support to minimize risk. The medium priority patient, which is the patient with continuous treatment, patient responding to lenalidomide, dexamethasone, consider discontinuation of dexamethasone and maintain response with lenalidomide alone. Prefer the prescription orally available drugs. If parenteral drugs administration is necessary, consider using it as a reduced frequency, like bortezomib, not twice weekly, but once weekly is enough. Use interval phone and or virtual visits. Reduce dexamethasone dose to 20 mg weekly. Consider G-CSF support to minimize risk of neutropenia. The low priority patients, which is stable in remissions on continuous treatment without active treatment, delay follow-up visits and or perform telemedicine, delay anti-resorptive therapy, as I said before, every 3 months. What about the patient with relapsed refractory myeloma? High priority patient with relapsed disease requiring therapy development of new SLEM criteria or significant paraprotein relapse or refractory myeloma. Treatment should not be postponed. Therapeutic decision should be made on case-by-case basis, considering disease stage, risk, cytogenetic, and comorbidities. Consider G-CSF support to minimize risk of neutropenia. The median priority for relapsed refractory patient in continuous treatment. If patient responding to lenalidomide dexa, consider modifying the treatment regimen to minimize needs for clinic hospital visits. Using weekly instead of biweekly administration of drugs like carfilzomib and bortezomib. Preference for oral agent, ixazomib, lenalidomide, pomalidomide, is switching to monthly administration of daratumumab as soon as possible. Low priority patients with relapsed refractory disease in stable remission on continuous treatment delay the zoledronic acid and denosumab every 3 months. The second patient is managing a patient with CLL and COVID-19. COVID-19 symptoms, mild versus more severe symptoms, may overlap with treatment-related pneumonitis or associated opportunistic infection. CLL disease burden, no mild versus significant symptoms, you can postpone treatment. Chemoimmunotherapy, target therapy, oral therapy. We have a very strange area in the BTK is a very good response rate with the COVID-19 patient, as you see in the next slide. The consideration for intravenous immunoglobulin replacement. Individualized assessment of a risk versus benefit. No COVID-19 infection, hypogammaglobulinemias, and severe or recurrent sinus, pulmonary, and or skin soft tissue infection requiring antibiotics. Consider reduced infusion frequency as possible, every 6 to 8 weeks, targeting pre-infusion of immunoglobulin 550 to 600 milligram per deciliter, and you can use the subcutaneous formulation. If the patient have COVID-19 infection, not a specific indication for IVIG, except if your patient have hypogammaglobulinemia. Close monitoring for thromboembolic events due to a higher risk for this patient as a cancer patient with COVID-19. The BTK inhibitor like ibrutinib or acalabrutinib having is anti-inflammatory effect. This has come from multi-center open-label study of ibrutinib in a patient with active chronic GVHD and an inadequate response to corticosteroid-containing treatment. It's about 42 patients. Patient has failed 1 to 3 prior treatment, ibrutinib 420 milligram per day until chronic GVHD progression. This is the CR rate, is about complete remission line. PR, the overall response rate is about 67%, stable disease in 7%, progressive disease only 2. So, what about the ibrutinib antipulmonary injury in COVID-19 infected patient with Waldenström macroglobulinemia? This is a case study. Patient on ibrutinib for Waldenström macroglobulinemia diagnosed with COVID-19. This is a 6 patient. Number of patient of 420 milligram ibrutinib is 5. experienced dyspnea or required hospitalization. COVID-19 symptoms resolving during follow-up. 5 patients from 6 taking the full dose of protonib has been completely resolved. Only patient at 140 milligram protonib has progressive dyspnea, hypoxia, and required hospitalization. Protonib helped for bilateral ground glass opacity in a chest X-ray CT. Worsening hypoxia started on supplemental oxygen plus azithromycin and oxygen for hydrochloroquine for 5 days without improvement. Day 5, a protonib 100 mg restarted with the tocilizumab 400 mg, improved the oxygenation and decreased the CRP. In a day 10, worsening hypoxia and CRP, mechanical ventilation. In a day 11-12, protonib were using with a full dose 420 mg, rapid improvement in oxygenation. In a day 14, discharged remaining on protonib 420 mg and still doing well. What about the acalaprotinib in a patient with severe COVID-19? 19 patients with severe COVID-19 received 10 to 14-day treatment with acalaprotinib, 11 on supplemental oxygen and 8 on mechanical ventilation. Gas exchange improved in a majority of patients. CRP and interleukin-6 normalized. Lymphopenia improved. 73% of the patients in supplemented oxygen cohort were discharged in a room air. 50% of patients in mechanical ventilation cohort successfully extubated. 25% discharged in a room air. This is not a cancer patient. This is using the acalaprotinib in treatment of COVID-19 patients. So,